يلا سمح.
السلام عليكم.
وعليكم السلام ورحمة الله.
موضوع سمينارنا اليوم هو Heart Failure in Childhood. المواضيع اللي راح نحكي عنها اليوم هي Definition, Pathophysiology, Compensatory Mechanism, Etiology by Age Groups, Classification of Heart Failure, Clinical Age Group, Differential Diagnosis and Reference. Definition of heart failure occur when the heart is unable to deliver adequate cardiac output to meet the metabolic needs of the body. Pathophysiology of heart failure. العوامل اللي راح تتأثر وتنتج لنا الهارت فيلر هن البريلود والآفتر لود والcontractility والheart rate. The preload, which means the volume and the pressure of the blood in the ventricle at the end of the diastole, while the afterload means the volume and the pressure of the blood in the ventricle during systole. The heart rate is the speed of the heartbeat measured by number of contraction of heart per minute, while contractility represents the innate ability of heart muscle اللي هي المyocardium to contract. Factors affecting cardiac performance. هسه ناخذ العوامل اللي تأثر على كل وحدة من هاي العوامل. Factor affecting the preload. First, total blood volume, venous tone اللي هو sympathetic tone, body position, intrathoracic and intrapericardial pressure, arterial contraction, and pumping action of the skeletal muscle. Factor affecting afterload. Peripheral vascular resistance, left ventricular volume اللي هن البريلود والwall tension, physical characteristics of arterial tree واللي هن elasticity of the vessel or presence of outflow obstruction. Factors that affecting heart rate. Autonomic nervous system, temperature and metabolic rate. And finally, the factor affecting the contractility. The sympathetic nerve impulse, circulating catecholamine, digitalis, calcium, and other inotropic agent, increased heart rate or post-extrasystolic augmentation, anoxia, acidosis, pharmacologic depression, loss of myocardium, and intrinsic depression. The compensatory mechanism. Compensatory mechanism developed to improve cardiac output, but in time, this response only served to exacerbate the underlying cardiac problem. This compensatory mechanism including three types. First, cardiac compensation and systemic compensation and neurohormonal compensation. The cardiac compensation including increased cardiac heart rates and contractility, then cardiac dilatation, and finally myocardial hypertrophy. While systemic compensation increased the blood volume and redistribution of the blood flow and increased the ability of the tissue to utilize oxygen. Neurohormonal compensation including sympathetic nervous system, renin-angiotensin-aldosterone system, and arterial natriuretic peptide and endothelin. In this figure, showing the pathophysiology and compensatory mechanism of heart failure. On the left side, the inability of heart to provide sufficient output to meet the demand of the body. مثل ما عرفنا يعني الهارت failure. A variety of disorder can lead to low output or high output failure.
No.
In purple color, the first compensatory mechanism increased sympathetic nervous system activity, and this leads to antidiuretic hormone secretion from the brain. The second compensatory mechanism, renin-angiotensin-aldosterone system, this leads to increased afterload, and then increased sodium and water retention lead to increased preload, and this affected heart inversely. This is called neurohormonal compensation and neurohormonal response worsening heart failure. On heart, the compensatory mechanism مثل ما قلنا increased heart rate and cardiac dilatation then lead to hypertrophy. While systemic compensation, this lead to pulmonary and systemic venous congestion. Now the etiology of heart failure. Etiology by age group, divided into age group. First age group, fetus. The cause including severe anemia like hemolysis, fetal maternal transfusion, and hypoplastic anemia, supraventricular tachycardia, ventricular tachycardia, complete heart block, and atrioventricular valve insufficiency for high output cardiac failure like arteriovenous malformation or teratoma.
No.
The second age group, premature neonate. The cause include fluid overload, patent ductus arteriosus, and ventricular septal defect and core pulmonary like bronchopulmonary dysplasia. Third age group, full-term neonate. The cause include asphyxial cardiomyopathy, arteriovenous malformation like vein of Galen and hepatic. والvein of Galen هو يعني malformation aneurysmal malformation in the brain. Left-sided obstructive lesion like coarctation of aorta, hypoplastic left heart, and critical aortic stenosis. Transposition of greater vessel, large mixing cardiac defects like single ventricle or truncus arteriosus, viral myocarditis, and anemia. The fourth age group include infant and toddler. The cause include left to right cardiac shunt like ventricular septal defect, hemangioma like arteriovenous malformation, anomalous of left coronary artery, metabolic cardiomyopathy, acute hypertension like hemolytic uremic syndrome, supraventricular tachycardia, Kawasaki disease, and post-operative repair of congenital heart disease. Fifth age group, child and adolescent. The causes, rheumatic fever, acute hypertension like glomerulonephritis, viral myocarditis, thyrotoxicosis, hemochromatosis and hemosiderosis, cancer therapy, for example, radiation and doxorubicin, sickle cell anemia and endocarditis, and cord pulmonary cystic fibrosis.
No.
Summary of etiology according to the most common age presentation and causes. هناك خلاصة يعني احنا مو حكينا الكوزز يعني شنو الأسباب اللي تصير بكل عمر. In the first week, heart failure is most commonly due to an excessive afterload being placed on the myocardium. And around 2 months, this is usually due to increased left to right shunt of the congenital heart defect that become apparent as the pulmonary vascular resistance becomes decreased. And at any age group, the acquired heart disease such as myocarditis and cardiomyopathy can be present. هسه طيفي كم.
Now I start with the classifications of heart failure. The heart failure is classified according to the course of the disease into acute heart failure and chronic heart failure. Also, according to the severity, into mild heart failure or complete compensated heart failure or moderate heart failure, incomplete compensated heart failure, severe heart failure, which means decompensated heart failure. Also classified according to the cardiac output into low output heart failure, due to volume overload and pressure overload and contractility problems. And high output failure, the heart rate is primarily affected by anemia arrhythmia and atrioventricular fistula. According to the function impaired, divided into systolic failure due to myocarditis or hypertension, and diastolic failure due restrictive cardiomyopathy and cardiac tamponade. According to the location of the heart failure, classified into left-sided heart failure, right-sided heart failure, and biventricular failure. The clinical approach to a child with heart failure, including full history, physical examination, investigations, and management. In the history, according to the age group, if the patient is an infant, we must focus by asking about the feeding and malnutritional status, poor weight gain, cachectic patient, and failure to drive. In older children, we focusing on asking about regarding exercise ability, fatigability, shortness of breath, weight gain or weight loss. Regarding the past medical and surgical history, we're asking about a recent viral infection, rheumatic heart disease, Kawasaki disease, hypothyroidism, or any surgical procedure related to the heart. Regarding the family history, focusing by ask about any history in family about cardiomyopathy, history of syncope or sudden death. During the physical examination, the physician should focusing on the heart rate, gallops, new murmurs, or displaced point of maximum impulse, displaced right ventricular impulse, and perfusion deficit. Pathological murmur or gallop rhythm is a characteristic for congestive heart failure. As a summary to a clinical finding during the history and examination, the clinical features in infancy regarding symptoms, there is a feeding difficulty, poor sucking, prolonged time to feed, sweating during feeding. Also, recurrent chest infection and failure to thrive. The signs: resting tachypnea, subcostal recession, tachycardia, poor peripheral pulses, poor peripheral perfusion, hyperdynamic precordium, precordial bulge, hepatomegaly, and wheezing. In older children, the symptoms are dyspnea, easy fatigability, and edema. Clinical signs: tachycardia, gallop rhythm, weak pulse. According to the location of the heart failure, if the left-sided heart failure is predominant, there is a tachypnea, orthopnea, wheezing, and pulmonary edema. If there is the right-sided heart failure is predominant, there is a hepatomegaly, edema, and distended neck veins. These signs commonly in adults and not usually found in children. For example, increased glandular venous pressure, leg edema, and basal cricosis. Now I start with investigations. Chest X-ray, not specific, but absence of cardiomegaly usually rules out diagnosis of congestive heart failure. ECG is not specific, but it's useful for assessment of heart chambers, left, right, or biventricular hypertrophy, and for detection of some underlying causes, for example, arrhythmias or ischemia. Echocardiography, it is a diagnostic test assessing the chamber sizes, myocardial function, and detection of congenital heart disease if present. Blood gas analysis shows hypoxia and metabolic or respiratory acidosis in severe congestive heart failure. Serum electrolyte level, especially serum sodium level, because infants with congestive heart failure often have a hyponatremia due to water retention, which decrease more with chronic diuretic therapy. The differential diagnosis of heart failure according to most commonly presentation. If the child presented with significant tachycardia, we must differentiate it from fever, dehydration, anemia, and pericardial effusion. If the child presented with significant tachypnea, we must differentiate it from respiratory infection, pneumonia, or acute respiratory distress syndrome, and acidosis. If the child presented with significant edema, we must differentiate the heart failure from acute renal failure, cirrhosis, nephrotic syndrome, and hypoalbuminemia. If the child presented with sepsis-like features, differentiated it from endocrine crisis or inborn error of metabolic. If there is a hepatomegaly, we must differentiate the heart failure from liver disease, storage disease, and extramedullary hematopoiesis. Treatment. There is a general measures to treat a child with heart failure. Oxygen supplementation, especially in the presence of pulmonary edema. Child allowed for resting during the daytime and adequate sleep at night, but strict bed rest is not necessary. Patient sleep in semi-upright position, 45 degrees. Keep the patient warm and gentle handling. Fluid restriction only if not dehydrated or in shock. Correct the anemia, electrolyte imbalance, treat concomitant chest infection. After the general measures, start with medications. Start with a preload reducing agent, which they interfere with renal reabsorption of water and sodium. For example, furosemide, which is most common diuretic used in pediatrics. It is a loop diuretic. Its dose in acute treatment 1 to 2 milligram per kg per 24 hour IV until clinical improvement. Then chronic treatment with dose 1 to 4 milligram per kg per day in 1 to 4 doses orally. The most common side effect is a hypokalemia of furosemide. So the patient require oral potassium chloride supplementation. Spironolactone, which is aldosterone inhibitors, potassium sparing diuretic, modest diuretic effect. Its dose 2 milligram per kg per day orally in 2 divided doses. The second type of medications is the afterload reducing agents, which acting by decreased peripheral vascular resistance to improve cardiac performance. Adrenal captopril, which is an AC inhibitor agent. Its dose 0.3 to 6 milligram per kg per day in 3 divided doses orally. Nitroprusside, it should be given by IV infusion in the intensive care unit, only for critically ill patients and for short time, only due its serious side effect. Its serious side effect is severe hypotension and cyanide poisoning. Digoxin is the mainstay in the treatment of congestive heart failure, although the combination of diuretics and AC inhibitors significantly reduce need to digoxin or even is no longer used in some centers. Its dose of 0.01 to 0.04 milligram per kg per day according to the patient age. Rapid digitalization is achieved within 36 hours by giving half of the total dose intravenously. Immediately then, quarter of the dose after 12 hours, and then the last quarter after the next 12 hours. There is some factors increase digoxin toxicity include hypokalemia, hypomagnesemia, hypercalcemia, myocarditis, prematurity, and renal failure. There is a specific etiologies that cause heart failure need a specific management according to establishment of this etiology. For example, if there is a congenital heart defect, we need a surgical or transcatheter treatment. If there is a heart block, we need a pacemaker insertion. If there is a post-infectious glomerulonephritis, we need to control blood pressure. And in acute rheumatic carditis, a high dose of aspirin is benefit. Thank you, Doctor.
Thank you very much for you and your colleague for this nice presentation. Okay. I would like to add some of the information, especially the practical ones for you. To start, بسم الله الرحمن الرحيم. السلام عليكم.
وعليكم السلام.
وعليكم السلام دكتور.
صيامكم وطاعاتكم.
وعليكم السلام دكتور.
Okay. Slides are shown on your.
نعم دكتور.
نعم دكتور.
Okay. بسم الله الرحمن الرحيم. Congestive heart failure, as you know, it is very important subject, and it is a medical emergency in different parts of medicine and in different age group, as you have mentioned. And you did very well when you start your presentation with the anatomy and physiology of this health problem. The understanding of the anatomy and physiology is very important and crucial to understand the pathogenesis of the forecoming of the sign and the symptom, in the interpreting of the sign and the symptom, and how to deal with the patient, including the anatomy and the physiology. As you mentioned, the compensating mechanism also responsible for the sign and symptom that we may face in the patient with congestive heart failure. For example, the tachycardia, and as you mentioned, that the explanation is the sympathetic stimulation by the adrenal gland. This is as part of the homeostasis, where the body start or adapt to maintain the normal environment, similar to what has been occurred in case of the bleeding, where there will be a vasoconstriction and the platelet plaque and the clotting factor activation. So these compensatory mechanisms, some of them are useful, but unfortunately, when the kidneys receive enormously or an error message that the body is in danger due to the low renal flow, due to the low cardiac output secondary to the congestive heart failure, it will activate the renin-angiotensin system with resultant fluid retention, and the sequelae of the fluid retention, unfortunately, will exacerbate the fluid accumulation in the body cavities, in the edema, in the pulmonary edema and in the leg edema and the congestion all over the body. So the understanding the pathophysiology is very important regarding the sign and symptom and to what is going with your patient. Etiology, as you have been mentioned, whether it can be classified according to the excessive volume load or excessive pressure load or abnormal myocardium function, all are right, and some divided the congestive heart failure as it is of two types, whether it is systolic failure or diastolic failure, or whether it is a preload or afterload, or whether it is acute or chronic. But what is the thing is static, is the similar pathophysiologic mechanisms in most of these etiologies and classifications. How we can interpret the following.
دكتور جاي تقلب بالسلايدات؟
yes.
دكتور احنا طالع عندنا بس اول سلايد طالع عندنا ما طلع عندنا.
اوكي. well.
اي تمام هسه دكتور تمام.
Okay. For example, there are three major mechanisms explains the sodium retention that may occur in congestive heart failure. First, a reduced glomerular filtration rate, and the reduced glomerular filtration comes from a decreased renal blood flow due to A, decreased arterial blood pressure, B, raised renal vascular resistance from generalized sympathetic stimulation, C, increased amount of angiotensin generated, and lastly, increase in the renal interstitial pressure to the elevated venous pressure. Okay. The second mechanism is an increase in the serum aldosterone concentration. This is very important, and don't forget that in one of the modalities of the treatment, we have to give a drug that acts against the aldosterone, which enhances the active sodium transfer from the lumen of the distal convoluted tubules to the blood, and the cause of the high aldosterone are prolongation of the half-life of aldosterone to the reduced hepatic blood flow that occurs with congestive heart failure, and decrease up to the 50-fold of the aldosterone secreted by the adrenals. The third mechanism is an increase in the renin secretion by the mechanism you know in the physiology. Well, if we revise the interpretation of the mechanism regarding the sign and symptom, we can say that in case of the pulmonary venous congestion secondary to the heart failure, then there will be a tachypnea. There will be a wheezing, there will be a crepitant rals, and there will be a feeding difficulties. These are much as an increased work of the breathing or due to the bronchial edema, alveolar edema, or interstitial pulmonary edema. And these are the dominant sign and symptom, mostly with the left-sided filling pressure when it is increased. There will be a systemic venous congestion. This is might be manifested as a hepatomegaly, peripheral edema, and antidiuretic hormone increased secretion. The hepatomegaly, from practical point of view, in the abdominal examination, what is the characteristic feature of the liver enlargement in case of the congestive heart failure other than the causes of hepatomegaly? Two characteristic features. First, the edge will be round. It will not be sharp. Yani the liver will be congested, so the edge, when you palpate it, it will be round. While if it is sharp, sometimes it is tender to palpation or to percussion to the congestion over it. Okay. Secondary to decrease in the cardiac output, then there will be a decrease in the precardial activity, there will be decrease in the arterial pulsation, the decrease in the capillary refill, and of the hypoxia, there will be irritability, Regarding the volume loading, the precordial activity may be increased, and there will be a gallop rhythm or murmur or approach according to the underlying cause. The adaptive changes, there will be a tachycardia, as I mentioned, secondary to the increase in the beta-adrenergic activity. The pallor, why the patient with the conductor is pale? This is due to the vasoconstriction. Why? Because there is increase in the alpha-1 and angiotensin II response. There will be low urine output due to decreased renal perfusion. The growth failure, this is very important, and we will take it later in the future in the seminar of the ferret thrive. One of the causes of the ferret thrive or growth failure هو causes of increased metabolic demand, hypercatabolic disease, as in case of episode of congestive heart failure or bronchial asthma or fever, bronchial, or any cause that increase of the metabolic demand. Why the patient with congestive heart failure had sweating, especially during feeding? This can be interpreted due to the increase in the sympathetic and cholinergic stimulation. Sweating. What about the sweating in the patients with the congestive heart, especially the small ones or infants? Most of the moms or parents complain that their babies had sweating on their head, feel hot. They sweat where their pillows are wet, especially when they arose. When they arose from sleep. The sweating itself could be just normal physiological phenomenon. It's not a pathological one. And just to remind you that the sweating is one of the sign and symptom of the ricket. Then what is the difference between the sweating in case of the congestive heart failure and the head sweating in case of the ricket? The difference between them is that the sweating in case of the ricket occur during rest, while in case of the congestive heart failure it occur during physical exertion, namely by the feeding. The most important physical activity is the feeding. Can be this is a normal? Of course, it cannot be done for the heart failure or for ricket. It will be just normal and familiar, but not so important symptom. Okay. Yes, the approach you had been mentioned is very good regarding the history and the sign and the symptom. I would like to add again that the checking for the increased jugular venous pressure is not important in the small children because of the short neck. Yes, I agree with you. The edema is a very late sign and not so important. Similar to the neck stiffness. Neck stiffness is not a reliable and early sign of the meningeal irritation in case of the CNS infection in the small infant and children. Opposite to in the adult one, where it should be very evident and important. And just to remind you that the absence of the neck stiffness does not exclude the meningeal irritation and CNS infection, the small ones. Similar to that of the edema, the absence of the peripheral edema does not exclude the congestive heart failure. These are important practical things I would like to mention for you. The other important thing.
دكتور اعتذر عن المقاطعه، الوقت خلص، راح اسده ونفتح ميتنج من جديد، نفس الحاله، سجل دخول من جديد.
اوكي
ان شاء الله.